Thanks for coming this morning. We're obviously in the last day. There's a nice segue into this presentation from the... Can you hear me? Yes. From the last presentation, I'm going to focus on ABAC, and if you're wondering if this affects you, I'm going to talk about a case study of very wide interconnectivity in the United States. If you live in the United States, there's a good chance what I'm going to talk about affects your health record and access to your health record. So in a different sense, I'm going to be talking about a case study of things that have already happened as opposed to things that are going to happen. My name's Tony Mallia. I work for Edmond Scientific. We're a small research and development. We have been running a think tank and doing prototype development as part of an agency contract for the last 5 years in healthcare privacy. And as a result of this, a lot of the essences of what's come out have been helped by the work that we've done. We work in health standards. We've worked in OASIS to do some of the SAML profiles. We work with HL7 in the security work group. But most of all, we have prepared and presented prototype demonstrations of health-related privacy controls. So, one of the things that is changing in this industry is that the patient-centric services are coming more into play. In other words, the patients are starting to have more and more control over what actually can be released and what happens. Particularly the control of information beyond treatment, payment, and healthcare operations. You will probably recognize this as part of the HIPAA high-tech laws, which governs the particular purpose of use under which a patient consent must be gained in order to make a disclosure. So the patient's expectations are starting to affect the whole access control mechanism, and it's not just a user ID involved, and we're going to explore this whole thing and how the ABAC, the attribute-based access control, starts to allow all these factors to be considered in an access permit or deny decision. Privacy concerns are increasing. We're getting segmentation, particularly with regard to sensitive conditions, and you're seeing rules now across the industry, particularly with regard to mental health and substance abuse disclosures. So you're actually starting to see factors in the attributes which are about the record. And health sharing across organizations requires the managing of federated identities, particularly of the patient. And we're going to be talking about two identities, the identity of the user and the identity of the patient. Sometimes, in the very simple identity-based access control, the user is the patient, and the correlation of those identities between the user identity and the patient identity allows the patient to gain access to their own record and only their own record. So that's the kind of simple case. But as you look across the health information exchange area, most of the activity is to do with clinicians and support people in the healthcare getting access to the record. This patient control over the record has got a sort of maturity to it. The top one is where the patient approves each request for each custodian. Basically, that has never happened. And the reason for it, it's going to drag down the healthcare organization into a complete stall mode, just getting access from the patient. The one that's currently in operation is that the patient is filing consent rules to each custodian, so that the patient basically declares this is what they want, this is what they allow, this is what they restrict. there is a vision further down of the patient being able to use a third-party consent management organization where they can place their consent directives, and then the organizations go out to that to pull the consent. And because of that, then the patient can actually put one consent in, and it applies to a whole lot of different organizations. We talked a little bit about ABAC, and the previous speaker it was a very nice introduction. We've migrated from ABAC through rollback, ABAC, the role-based access control, and I don't need to explain that, into the attribute-based access control, which has not got rid of the other mechanisms. You can still have identity, you can still have role in the attribute-based access. But what the attributes are about now is a set about the user. We'll look at this in more detail. The context of the request. What were they trying to do? The subject of the information, i.e. the patient. What's the information about the patient that is needed to make this decision? What is the information content in the health record itself? For example, are there protected conditions, as we talked about, and some of these are controlled by regulation. And what is the consent of the patient? So you're seeing all these coming together to make the automated runtime decision on whether to release or withhold the information from the user who's making the request. And I don't expect you to have to read this, but this is part of regulations of where authorization is not needed by the patient and where it is. And so this is all law. So it basically says if you go outside this, you basically have to get the written authorization required by the patient. Now this is the basic law. This is HIPAA high-tech. When you go a little bit further, you're actually going, let me go. When you go a bit further, then there are other regulations that we'll look at which cover some of the sensitive conditions and so forth, 42 CFR and other particular regulations. So in this whole mechanism, what we're talking about, particularly between the organization, is a trust framework, which out of this, the most important thing are the security and privacy policy framework at the bottom, which says, how is this decision-making going to happen? So what I'd like to show you is a real deployment of this, very wide-scale deployment that you may or may not know about. And that's the eHealth Exchange. How many have heard of the eHealth Exchange? A few. It's possibly not well known because partly these things get well known when there's bad news. And this has been around for 6 years. And it's a health sharing network in the United States. This slide, or the information for this slide, is from the not-for-profit organization that runs it called Sequoia. The URL for Sequoia is at the bottom. It's sequoiaproject.org. This is the size of this right now. It's in 50 states. There are 4 federal agencies linked into it. DOD, the Veterans Administration, CMS, and SSA. It's at 65% of all hospitals. And that covers something like 50,000 medical groups, dialysis center pharmacies, and it's supporting more than 100 million patients. And this is an exchange mechanism where somebody on the network can go and access the patient's record wherever they are on the network. They can aggregate the information from the various sources. It's typically used in 2 purposes. One is for the transfer of care. So if you've been with one service provider, one healthcare provider, and you're going to move to another, this is a way of moving the records across kind of as a one-time deal. There's a second one, which is what I call concurrent care. In other words, you're actually seeing multiple care providers at the same time. For example, if you're a veteran, you may be seeing the VA, and you may also have a private healthcare provider. And they're not in a formal relationship between each other, but now you've got prescriptions and various things going on between both care programs. And this allows the exchange of that information so you can see what the prescriptions are, what the lab results are, so they don't have to be redone by the other care provider. So this has gone past its critical mass stage. In the last year, there was 35% growth in this participation. With 100 million patients, we're probably somewhere at 40% of total coverage in the United States. And at that sort of growth, it's going to be ubiquitous. So the big challenge in this is, now what do we do about access control? How is that actually managed? So let's talk about ABAC in the eHealth exchange. We're not talking about the access control within the healthcare organization, which legally is called use. It's not called disclosure. Disclosure, as a name, is when you send the health information outside the covered entity. So in the eHealth exchange, the trust framework is a legal document called the DIRSA. And the DIRSA is the Data Use and Reciprocal Service Agreement signed by all participants. So the participants don't need to get into point-to-point relationship with each other. There are something like, of all the participants that run their own health information exchanges and join the eHealth exchange, about 400 of these points. And as I said, that's the stuff that's growing. The user attributes and the context, which is known in the request, is passed in SAML. And it's passed in a profile of SAML called EXPA, which defines the attributes that are actually going to be passed. The sorts of attributes that are there is the user identity as authenticated. So we can use identity-based access. The authentication strength. So in the policy, you may want to determine whether this was an ID password level of authentication or an X509. And in the majority in the federal space, you're finding that the X509 is the way that you need to go for a level of assurance 4, which is required to access the patient record. The role can be passed. The role is a controlled vocabulary. And so in a lot of cases, for purpose of use treatment, you're seeing the role being a medical doctor, but there are other roles inside that. And then the organization that user belongs to. And this is particularly important. The context that's passed is the operation requested, the purpose of use, which is a controlled vocabulary. So treatment, payment, operations are purposes of use, as well as things like coverage. And coverage covers things like insurance, SSA, most of the SSA transactions are coverage because you're getting some benefit out of the medical record that they acquire. The patient whose record is requested is part of this, obviously, because you're requesting information on a particular patient. Now, the identities of the patient are issued typically by the organization that's managing their care. These are not nationwide identities to the patient. So there is, in part of the exchange, there's a whole correlation protocol that goes on to match the identity of the patient in one system with the patient in another. If that correlation fails, then there's a good reason in the access control mechanism for not allowing that organization that's making the query to access that patient because they don't know the same patient. They don't have a relationship with the same patient. So that's pretty critical in treatment. If you're asking for the patient's record, you'd better have a previous relationship with that patient. Otherwise, why are you asking for this? And so that stops a whole lot of phishing type mechanisms by actually correlating the patient and saying, we now know that the patients are correlated, that you know this patient and you know this patient, and therefore there's good reason for exchanging information. Now, the making the decision to disclose, we started to collect some of these attributes. Our regulations, we talked about HIPAA, 42 CFR, there are other federal regulations. There's Title 38, for example, on the Department of Veterans Affairs, which has a different set of sensitivity conditions where consent is required. Organizational policies, federal and state regulations, the rules must be executed in real time because the things can change. The rules consider multiple attributes, and there are a lot of attributes beyond identity that we've actually covered. So how does this kind of work with the technology? Well, the security is really based on SAML and XACML. People familiar with XACML? So it's a standard out of OASIS. It has two pieces to it. It has the protocol that makes the request to get the authorization decision, what must be sent up, and then there's a rule language in XACML which executes the policy and then gives a permit-deny decision back to the policy enforcement point. If you were looking at the previous speaker, policy enforcement points are embedded into the chain, and it's the policy enforcement point that says whether this particular operation is permitted or denied. So it was based on SAML and XACML. All these attributes are passed with SAML, and there is a connect gateway that was built. It was actually a federal contract under ONC and the HHS to build this. It is now in the open source community. The connect gateway has all these mechanisms for intercepting the traffic and making the XACML call up to a PDP, a policy decision point. So the policies are written in XACML, and they have to go through their own life cycle because we're talking about an individual organization protecting its boundaries under the rules of a jurisdiction for that particular organization. If it's a federal agency, it's under certain jurisdictions. If it's a private sector, it's under different jurisdictions. And there are different rules. So each organization basically protects its boundary with that mechanism. Now, what's actually happening in the future here is there are new protocols on the horizon. This has been going for about 6 years now. It's all based on SOAP. It's based on standards from IHE, and the industry is starting to move away from this more to the REST-based protocols. Now, the issue then becomes, with REST-based protocols, what do you do with SAML? And this is kind of the hot topic of, with these different protocols, how do you pass these attributes in the request? So we need to control the authorization with these new protocols. OAuth 2 looks like being a major candidate for access control. Now, if you look at the complexity of this access control, it needs something behind it that's going to give it the horsepower to execute the policies. And we think that the OAuth authorization server needs an ABAC type control behind it, which is executing these types of policies. So the work we've been doing on this, so most of this other work we've been involved in. I was involved in the foundation of the eHealth exchange. I wrote some of the specifications, the authorization framework of how the SAML would be passed. This is quite a while ago. So what we need is a hybrid authorization mechanism which will bridge the old and the new security protocols. So the concept that we've been working on is a bridge which allows the attributes from OAuth discovered in the credentials that are passed from the user. You only get the user stuff in OAuth, you don't get the other stuff. That can be integrated with the other attributes and then passed into a PDP with an XACML protocol. This looks particularly exciting because as we look at the migration of technology, you can't just say, here's the new one, get rid of all the old stuff. Doesn't work like that, only in greenfield. So every time somebody puts up, here's a brand new way of doing this whole thing, there has to be a plan of how it can be integrated, how the old stuff will continue to work, and how the move across will actually happen. And if you don't have that plan, the new stuff can't go in except in a greenfield somewhere. So the idea here is that we can keep the policy engines, we can keep the policy language, and we can apply it to both SOAP-based protocols, which carry the SAML, and OAuth-based REST protocols, which through the retrospection to the authorization server can give us the attributes of the user to inject into this decision-making process. So we're I think we're still ahead of time here. So I wanted to talk a little bit about Edmond Scientific and what we've done. I talked about the think tank, but we own proprietary technology to bridge OAuth into XACML. And that, we believe, will allow us to get to the OAuth type of access enforcement in the REST-based protocol, which includes the new health protocol called FHIR. And we have the proprietary technology to do this bridging. As I mentioned, we co-authored the eHealth authorization framework specification. We have done through the think tank multiple demonstrations of OAuth at the HIMSS 2017, including use of UMA, the UMA profile for OAuth, in a cascading mechanism where the custodian of the record has an authorization server and the patient-controlled piece has an authorization server, and there's a delegation of the control out to that. That's just another way of implementing consent directives. And then behind the other authorization server, we've put the FHIR consent repository. There is a consent directive standard for health in the FHIR, and so there's a standard way of submitting a consent directive and retrieving it, and therefore by processing it. And really why we've come to this conference, and this is our first time to this conference, is we're very interested in working with others to produce a complete solution. We think that it is relative, if it's done right, it's relatively simple and you don't have to rip out everything that you've already done. And we think this way of distancing the policy engine from the enforcement point and running both an OAuth and a SOAP-based, and you could run something else with the same concept, allows you to unify your policies. Because if you delegate the policies down to the individual applications, you're going to get a different interpretation of those policies. That's going to give you backdoor. Because basically you can go through one system, you've got different privileges from going through another system, and suddenly one system has compromised the security of the other one. So you really need to move to this unified approach to the policies. And I would also endorse the previous speaker about the complexity of the policy declaration. We're just going through languages for policy declaration, how that relates to XACML, and how you test an XACML-based engine to make sure that somebody who was working on the project didn't put a backdoor in there. And that's kind of one of the big concerns, is what happens if your policy engine is corrupted? You've got a serious issue here which could go to systemic breach. And systemic breach is very, very expensive in penalty. So that is all I have prepared, and I would encourage questions if you have some. Yes.
I have two questions. The first one is a quick question. What attributes are used for the patient identity? Is it name of the patient or insurance ID number?
Patient identity. The patient identity, the pure identity, is not the attributes that are describing the patient. In most of the HL7 standards, it's an assigning authority with a number. It's a combination of two values. The assigning authority is the authority that issued that number, and then there's a number. So the identity doesn't tell you much about the patient, but it is the unique identity because it's qualified. You can't ever get duplicates of that identity. But the traits that are associated with the demographics are the ones that determine whether these two patients are identical. If they're identical, you have got a linkage between the two identities, assigning authority identity, assigning authority identity. And that's the basis of the master patient index and that whole area, is to keep those relationships. So identity is just two numbers, really, or two strings.
Okay, and the other question related back to your slide where you had said that if there's no relationship between a facility and the patient record that they're requesting, that the request would be denied. So for the purposes of that relationship, if I'm a new patient who goes to an emergency room at a hospital in Chicago where I have no previous relationship, but they request my medical records, would they be able to get them from the health exchange?
Absolutely. Because what's going to happen is you're going to, even in the emergency room, you're going to get registered. And they're going to capture as much as they can about you, particularly your identity, first name, last name, date of birth, hopefully social security number. Social security number is a whole other discussion. It's a very, very valuable identifier. But in certain cases, it's not allowed to be disseminated. So so you get the number of these things, and then it does usually it'll do a probabilistic match out to the network. That's the patient correlation part of the network, is to find where you are known now. You arrived at the emergency, where were you known and where are your records? Well, thank you very much.